Hello, welcome everyone to Students for Urology National Teaching Series. This topic is going to be on urinary retention. My name's Sean, I'm one of the core committee members, and we're joined by a heavy consultant presence of Mr. Fernando, Mr. Danasakaran, and Mr. Mack as well. And without further ado, I'm going to hand you over to our speaker, Mr. Saeed Siddiqui, to give you this presentation on urinary retention.
Thanks, Sean, for introducing. Good evening, everybody. Nice to meet everyone. Thanks for all the consultants who are going to be supervising this and keeping me right. Thanks, everybody, for attending and taking time out. And I'm sure it's been a work day, busy evening. So hope it's a bit helpful for people who are sort of in foundation training and interested in urology or just in anything else, because urinary retention is quite a common presentation, isn't it? So I think we'll get started. I'm happy to take questions in the middle if people like. I don't know whoever Sean wants to do, or if the consultants want to budget and stop me somewhere. And let's just keep it nice and informal if that's okay with everybody. I might not share my video because my internet connection is not very stable, so I don't want to get stuck in the middle. Cool. So we'll start, and hopefully here we go. So urinary retention, actually very common problem you'll see in A&Es, in your cherries wards, in urology. We see it all the time. You'll see on surgical specialties. So just something for people to know about and to know what to do, and just to sort of even get a diagnosis at a junior level is quite helpful, because you get referred all sorts of abdominal pain as retention, which is actually not retention when it becomes a problem. Anyway, urinary retention is the inability to pass urine voluntarily. In terms of broad differentiation, you can divide it into acute and chronic. Acute retention is what you would deal with mostly in a non-specialized setting, either through in GP or A&E or in your general medical take, where you might see a patient with an ability to pass urine and it's painful and they can feel their tummy and they're just crying out in pain. The other type of retention is chronic. That's a bit different, and there's a bit more pathology involved mostly with it, not always, but mostly. And it's essentially in chronic retention, you've got incomplete voiding of urine. So even though you've passed a little amount, you'll find that these people will have a lot of frequency. They'll have incomplete voiding, they'll need to go again and again. And with your acute urine retention, you just call it normal pressure urine retention, where with chronic, you can develop an element called chronic high pressure urine retention, which becomes a urological thing to deal with in the long term and in the short term as well, or at least until somebody's put a catheter. But we'll talk about both those things later on in the talk. In terms of incidents, fairly common, very common actually. Male to female ratio about 13:1, and it becomes quite common as men grow older. It's just because men have a more complicated lower urinary tract than females in some ways. There's more anatomy there, which can cause blockages most likely, and that's mostly what you see in urology as well. So if you're a 70-year-old male, you've got 10% risk of chance of having one episode of acute retention of urine at some point, and it becomes about 33% when you become 80. So a significant jump there. It gives you a significant amount of hospital admissions in the UK as well. This was statistics taken from NICE, I think, which said 30,000 hospital admissions in the UK, and many more visits were because of acute retention of urine. And about 86% of presented people in this cohort were men, and only 14% were female. As you know, although acute retention of urine is a fairly simple thing, it can have a significant impact on the patient, because when these patients come in, they will be in agony. They will be in agony because they won't have been able to pass urine for hours, sometimes even longer if they've sort of tried to power through it. It can be as traumatic for some people, or it's been noted in some quality improvement sort of a service, or in some patient factors where people have said it's almost as bad as getting diagnosed with a stroke. I'm not sure how much you can characterize that, but And then if some patients need catheterization for longer, then there's always that deterioration in their quality of life, because if you see someone with acute retention of urine and you have to send them home with a catheter for a few days or a week, or we can talk about those things, but it does change their quality of life. They have to be dependent on something which they weren't on before, and that can have a significant impact on people being able to go home. Sometimes if they're more frail, then it can have an effect on their discharge planning and maybe needing more care or support if they have needed some before. Just to keep it simple, to differentiate the causes of retention of urine, I've listed a few. This is not an exhaustive list, but I think most of these things we'll hopefully cover. So most commonly, what you'll see in urology is obstructive causes, and that tends to be, again, more in men than in females. But infectious and inflammatory causes are also significant, especially, but these sometimes tend to get dealt in the community more than people needing to go into hospital for this. Then drug-induced causes, for example, post-procedure, post-anesthetic, neurological, and then there's all iatrogenic as well. In terms of your obstructive causes, simple stuff, and you can start from the most distal part of the male anatomy, and you can start from the meatus, and the meatus can get stenosed. You can have a paraphimosis or a bad phimosis, which just makes that your outlet is not being able to open. There's nothing coming out. And then as you go up or higher through the urethra, you can get strictures or stenosis all throughout the urethra. You get to the prostatic urethra, you can get big prostatic hyperplasia that causes narrowing of the urethra. Again, that can lead to sort of blockages of your lower tract, and then as we know, synonymous with the benign prostatic hyperplasia. Other causes can be fecal impaction or constipation. Malignancy both in the urothelium or the urinary tract and the gastrointestinal tract, and in females, the gynecological malignancy, cervical cancer, uterine cancer can also lead to sort of obstructive causes of retention of urine. In terms of infectious causes, most commonly, I think UTIs are one big precipitating factor for urinary retention episodes, acute retention of urine episodes to be precise. And other ones, again, common, but not as common as UTIs, would be your prostatic abscesses in men, which is in some ways a complicated UTI or a prostatitis diagnosis. In terms of drug-induced, your opioids, your anesthetic agents, benzodiazepines, you'll see retention of urine every now and then. You get referred patients from the psych units or psych facilities because patients have been started on new antipsychotics, and they can also interact with the way all your parasympathetic and sympathetic nervous systems are interact and can cause you into retention of urine. Anticholinergic drugs, sometimes we consent for example, for after we inject botulinum toxin into the detritus, that can also cause it. So that can be induced some ways, but you mentioned them when you do these procedures to these patients. And as you mentioned, the neurological source sometimes overrides into the psychiatry, but there's a few other causes neurologically specific as well. And that could be either problems with autonomic or peripheral nervous system. The causes might include Guillain-Barré, radical pelvic surgery, causing spinal injuries or nerve root injuries, and specific symptoms like multiple sclerosis, Parkinson's, and cord equina or spinal cord compression. Just a brief sort of slide to remind everybody, anatomy and physiology. You know, we've got two kidneys, two ureters coming in, joining into the intramural ureter back into the bladder, and then open up into urethra. After the urethra is where the slight differences occur in the male and female anatomy. In the male, you have a penile and a posterior urethra surrounded by prostate. Both male and female will have internal and external sphincters, which help you control the external sphincters, where you control your somatic sensations and sort of habits of urination, where you get voluntary control. The parasympathetic system will help you sort of contract and gets the bladder to contract, and urine helps to pass through that. And the sympathetic system, on the other hand, does the opposite and helps to relax and helps in the storage function of the bladder. So you can imagine that the complex system of sympathetic, parasympathetic, and nerves all involved. If you've got damage at any level, you can have an effect, especially, again, as we said about spinal cord compressions, if you have tumors around the levels of the spinal cord, that can affect on your urine habit. And that's why I think one of the things with acute retention of urine is always to make sure you think about acute causes of spinal cord compression, such as cord decline, etc. I think I was hoping to make it a bit more interactive from here on forward. So we've got a case. I don't know how many people are in, and if anybody wants to sort of see what to tackle this with. So I'll just leave it open, and if anybody wants to answer. I'll say there's a 79-year-old man who's presented with severe suprapubic tenderness. He's not passed urine in 6 hours. He's been experiencing constipation, he says, for a few weeks. He's not passing any urine for you to get specimen. It's got past medical history, which has been noted over there. Now, if you're the F1 or F2 in A&E or in the acute medicine ward or in your GP practice, wherever this is presented, do you have there's a lot of information already there, but just wanted to see if people have an idea of how they would want to deal with and what they would do with it. Does anybody want to volunteer? Give us an answer.
Do you want to make a start, Saad, and then we'll...
Yeah, sure.
Or people typing, actually.
Oh, yeah, people are typing. I know. Let's see if I can keep those both things together. So I think as you would, as with everything, just I think somebody said bladder scan, but that's good. But I would just stick to basic. You'd obviously make sure, and I'm sure all of you would. You would start with a A2 assessment. If somebody's acutely unwell, you want to just make sure that they don't need anything getting done ASAP. And once you've done that, then you can go into the specifics. So you take a brief history. You get an idea of what this person's. The history is already there, but yeah, you would start with the history, get an examination done, get an idea of what this person's problems might be. The way I like to sort of always do stuff is I like to see what the problem is, why the problems happen, and how it has happened. And those things will help me identify what I can do to sort of make a change for this patient here, or what I can't do, and if I need someone else's help here. But yeah, those are the questions you would ask essentially. And then rightfully said, you'd go on to a bladder scan and see what's going on. And the history is quite convincing that this guy's probably got urine retention, but a bladder scan is always helpful. It's point of care. It's available fairly routinely in pretty much every part of the hospital, but it gives you a fairly good idea that this person's got retention of urine and they need something getting done. Specifics to cover when you're taking a history in patients with sort of a focus on urology is, again, you stick to the basics. You say, how did it start? What happened? How has this progressed? And then I think this is a good time sometimes, maybe not in the acute setting where the patient's feeling unwell or has a lot of pain, but when you come back to them, you want to get an idea and assessment of if they've been unwell in terms of fevers, in terms of have they have symptoms of the lower urinary tract before? Is this their first episode? Have they seen any blood? Past urological history is very important in these patients because a lot of them will have some other stuff going on. Not all of them, but a few of them might have some other urological history going on as well. A drug history is important. Alcohol history is important because it gives you an idea. Sometimes you can see acute intoxication with alcohol can also lead to retention of urine. You'll see these patients here and there, especially younger patients where you would not expect this to happen. Examination will tell you that you'll find tender enlarged bladder, which will be Daltopicus, and sometimes you can get all the way up to the pubic symphysis, but not always, but yeah, up to the level of the umbilicus. And when you do an examination of the genitalia, again, this is very important before you decide to see if and how you're going to catheterize someone if they need an indwelling catheter, because if they've got a pinhole phimosis or if they've got a foreskin which is not going to tolerate a catheter, then there's no point you trying to mess around with it. You might need senior help, you might need a specialist input. But yeah, examination of the external genitalia is also important as part of that, because a lot of times people assume that it's going to be normal examination and move on to the next step, and then they say, well, actually, I can't really proceed here. In terms of management, it's fairly simple, and pretty much everybody probably understands that they'll need some form of decompression. The easiest thing is to get a Foley catheter, suitable size depending on how you made it, I think, as a rule of thumb, 14 French in hospital is fairly reasonable. Sometimes there's school of thought where people say the smaller the better, but when they've come into hospital and they've been unwell, I think a 14 and 40 is not a bad size to start with. I think I always recommend people using 2 instiller gels because when you've got someone with acute retention of urine, they'll be constricting their muscles in the pelvis. They'll be in agony. They'll be in pain. Instiller gels are not only helpful sort of as lubricant, they'll give some sort of soothing effect afterwards with the local anesthetic effect, but they also help you get enough into the cavity. So I think instiller gels are very nice and helpful, and I think use 2 if not 1 at least. And then you can get a gentle sort of attempt at trying to catheterize this patient. I didn't go into the sort of ANTT and techniques because everybody must have seen this in med school, and this is a part of the GMC guidelines. So everybody knows, I'm sure, how to do a catheterization with the non-touch techniques, and just keep making sure you've got 2 gloves, pairs of sterile gloves, and got a clean and a sterile and a dirty side to get a catheter in. I think the important thing is that you can try gently, try to make sure that you've got the anatomy extended where your penis is upright. If you're dealing with a male, the penis is upright and stretched, and you can get yourself a good shot at getting this catheter. But if you failed and if you've not been trained to do anything else, then you need some senior help, maybe your senior in the department or the help of a urologist. And then there'll be other sort of things which might need to be considered depending on what the problem is. And those things include curved tip catheters or guide wire catheters or flexi guided catheters. And sometimes, if none of those things work from the approach down below, then suprapubic catheters into the tummy. But again, that's a bit more special in terms of what needs to be done, because you need to identify exactly what the problem is. Once the catheter is in, I think very important to send off a urine sample for microbiology and culture to make sure you've got hourly back to monitor the urine output and also to monitor the post-void residual. So as soon as you put a catheter, the patient's going to empty X amount of urine. That's what's being held in their bladder. And that's a very important value to decide what needs to be done next. Second thing is to monitor that urine output hourly. And I'll come into why that becomes a bit important later on. And that's because you want to monitor for diarrhea. So you want to see if this patient's had some sort of problem which is a bit more chronic than very acute, and they're going to diarrhea, which is produce a large amount of urine per hour rather than a limited amount of urine which you would expect for everybody else. And then once you've dealt with this problem of retention of urine, then you go on your fact-finding mission to identify what's actually gone on. Is this a one-off episode? Is this because there's an episode of UTI? Is this because this gentleman or this female or someone's been intoxicated with alcohol? Is it because they've had an operation? So you want to get to the bottom of the story and see why this has happened. Because that will determine what you do next. I think the next steps of investigations are, as I said, you send urine cultures for mostly everybody who's had a retention of urine. I think we do that normally in our practice. The other things which include routine bloods, there's less controversy about it. If you've got barn door retention of urine, very straightforward in and first time episode, your post-void residuals not anything greater than 400 or 500 mils, then the likelihood of anything being significantly wrong apart from everything else is unlikely. So you wouldn't do bloods and cannulas and everything on them, but I'd have a low threshold to sort of investigate them if they've come to hospital and if got a higher residual volume and they're especially diuresing and they look like they've got other comorbidities as well, because it gives you an idea. And it brings into pictures of the kidneys and sort of high pressure, but we could talk about that later. I think I've mentioned high pressure here because I didn't want to miss it. But again, essentially, patients who've had a very large residual urine, about more than 800 to 1,000, and they've got increased urine output hourly, which is more than about 150 to 200 mils of urine per hour, you start to worry about something called high pressure retention of urine, which is a chronic process rather than an acute process. And those patients, they'll need a catheter long-term and a review with urology. But in the acute setting, you need to monitor them to see if they're not removing all of their hydration statuses through the urine. And initially, you give them a period of time to sort of drain out and work the kidneys extra, but you want to keep an idea of how bad the kidney function is with the help of using even those cohort of patients. Keeping on our acute retention theme, if, for example, you've had someone who's had 400 mils, you've done a urine dip, there's nitrites and leukocytes positive, you think this guy's got UTI, that's what's triggered all of this, maybe it's got some mild LUTs, and this gentleman, say, and 79 in his case, maybe he could be a 50-year-old or 79-year-old. Or, for example, the constipation case when we talked about in this gentleman, then you want to address those causes of either the constipation or the UTI. And if there's nothing else found, then you can attempt a trial without catheter. I think there's a good amount of research to say that if you've got males who've had a retention of urine episode, and if there's no contraindication, starting them on an alpha blocker in the form of tamsulosin is very helpful. It increases the chances of a successful talk by almost by 18 to 20%. And the good thing about the alpha blockers is that they work fairly instantly or very, very soon after you've commenced them. So you can start them, and within a week you can try to arrange a trial without catheter. I know services are different in terms of places of the country. Some units will have availability of drug within 5 to 7 days. Some take longer, about 1 week to 2 weeks. But yeah, a reasonable option would be that this patient, if they've got no evidence of high pressure urinary retention, and if it's an acute retention episode, then a trial without catheter. If you've addressed the cause of their retention of urine, then it's fairly reasonable to arrange a trial without catheter. Just a second case to talk about. If anybody wants to sort of, again, I will leave it open to the floor if anybody wants to reply. You're one of the surgical SHOs. You've got a 65-year-old who's admitted through A&E. Again, this gentleman woke up in the morning. He wasn't able to pass urine. He was catheterized by the A&E doctors for you kindly. But they've done blood tests on him, and they've said that he's got an AKI1. So what are the things you want to think about and talk about in this patient? And I think we've mentioned and touched a few, but I just thought this case would be a good sort of example where we could come across those things and combine them into one to make sure we don't miss anything. Anybody want to add anything there? Give it a few seconds. So I think with this case, I'll go through this stuff later on, but what I wanted to mention and I want to highlight was high pressure retention of urine, essentially, which is urinary retention, but causing a high intravesicular pressure that causes to break the anti-reflux mechanism of the bladder and the uterus, and there's a backup of urine which goes up towards the upper tract, which leads to hydronephrosis, sometimes hydrouritis, and then ultimately increases the pressure in the sort of collecting systems to a level where the kidney function starts to deteriorate. And if you leave this for long enough, it becomes a irreversible process. And I think the important thing is that if you get someone who's presented to your services with evidence or suspicious of high pressure retention of urine, then you have to be very careful to make sure that they do not get talk without a review with urology before. And ideally, we should not be arranging talks unless they've been seen by urology or have had plans made by urology teams for this, because you want to save their kidney function and make it reversible and get into that element of reversible kidney function as much as possible. So this gentleman who's come in with a bit more vague history, the way I would sort of go on and see this patient again, after they've been catheterized, I would make sure I've got urine output hourly to monitor for this gentleman to see how much they're producing. As I said, when you've got high pressure retention, these patients will diuresis, their kidneys going to sort of overdrive. They've been loading onto fluids for weeks, days, months sometimes, and they've got a lot of fluid in the third spaces, which they want to try to get rid of, and the kidneys try to push a lot out. People can lose almost up to about 8 liters to 10, sometimes 12 or 15 liters of fluid through the urine in high pressure cases. So you have to keep a close eye on the urine output. You want to assess it. And if you've got a urine output of more than 200 for 4 hours, then there's a strong suggestion that this should be replaced in the form of IV fluids or oral intake if it's at about 50% rate of hourly loss. And anyone who's got a residual of more than 800 mils to a liter, I would make sure you monitor your urine hourly for at least 4 to 6 hours to see if they're diuresing, and to ensure you get some sort of bloods on them to make sure that the kidney function and to get an idea of what the kidney function is doing. Again, I think we've talked about those. You'd always, in cases where you're suspecting high pressure, you would do a kidney function test, you would do baseline bloods, you'd send the urine off for culture. If there's a diagnostic uncertainty, then ultrasound KUB of the kidneys will show you some sort of hydronephrosis, which would confirm your diagnosis of a high pressure retention. And these patients, I think the key thing from a junior perspective or a perspective of not working in urology, if you are not working in urology, is to make sure that they have a long-term catheter. Plans for talk are not made without either referral to urology or discussion with urology. And I'm not saying every patient you think will have high pressure, because once you discuss with urology, maybe there's a difference going on and they might recommend a talk, but I wouldn't arrange a talk without discussing with the urology team in your local trust. I think this is just for more information purposes. I know that because we're doing a urology based teaching, I know most people in this meeting will probably want to, as juniors, maybe consider urology as a career. And if people come in with high pressure retention or retention of urine, there's a few things you can do in the outpatient setting which people will consider, which is sort of flexible hysteroscopies or PVRs and flows with sometimes a very close monitored talk. And ultimately, if it's all found that it's because of outflow obstruction or because of benign prostatic enlargement, then ultimately if patients fit enough and they've got no contraindications, then surgery can be talked about, but that's after discussion about medical therapy. So it's more of an information side rather than anything else. I don't want to complicate stuff, but I'll just mention it if people are interested. I think that's most of what I wanted to cover. Should we open the floor up for any questions or if the consultants want to add on or change anything from what we've talked about, then
Thank you, Zahir, for your presentation. I thought that was really, really useful just in terms of a practical setting of myself as a foundation doctor as to what to expect when I'm in ED and how to go about managing it from a realistic standpoint. I'll just open up the floor to see if anybody has any questions. Feel free to type them in the chat if you'd like. And if not, then maybe the consultants can add one or two things based on what you said in your presentation.
I've just seen this question. So I think it's very difficult to sort of base it on a value of value of urine on a bladder scan. Essentially, if somebody is not able to pass urine and they've got pain and they're in painful retention of urine, then they'll need a catheter. You'd find it very hardly that it would be a value of less than, say, 300. But I think anywhere more than 300, you would want to catheterize them, especially if they've got painful inability to pass urine, and somewhere around greater than 300 or 400, then I would catheterize them. But essentially, you want to see what is going on apart from if somebody's got inability to pass urine at 100 mils, I tend to say to the nurses or the doctors or juniors on the ward, say, let's give them a bit more time. Let's give them a bit more to drink, see how they pass on. If maybe they'll pass urine by themselves without needing a catheter. But if it's got to 300-400, then I sometimes would just say, yeah, let's catheterize them. But I don't know if the consultants have a specific value, but I think it's a bit difficult to put a number to it.
That's right, Saad. Just, it's difficult to put a number to it, but as you say, a palpable bladder or acute retention and a convincing history that he has not passed urine, which is often the most difficult thing, are probably the reasons you put the catheter in. And I think it was a nice talk, good summary. I think you covered quite a lot of ground, and it's quite difficult to though it's a straightforward, it's a simple thing. Retention, it's quite a big topic, and there are multiple ways things can change clinically. So that was good. The few things I wanted to mention was at the beginning, we talked about, so retention in my mind, when I tell it to my trainees are essentially, when someone says retention, I try to bracket them into 4 groups. One is acute painful retention, which you talked about. Another is high pressure retention. And then the third is, which is chronic high pressure retention. And then third is an entity called chronic retention, which is low pressure. And this is sometimes you get called from the medics who say they've got a patient who did an ultrasound scan. Patient was comfortable, his renal function is normal, and his bladder scan or his post-word bladder scan or his ultrasound scan has picked up a 1.52 liter residual. And patient says that he's been passing urine okay. So this is one entity. It's called low pressure chronic urinary retention. You probably will be getting it once or twice a year from the medics, from the care of the elderly. But it's important because if a patient has got a normal renal function and he's got ultrasound or clinical bladder retention, so you're holding up to 1.5 to 2 liters, the general tendency is to put a catheter in, which need not be done. So low pressure chronic retention, you don't need to catheterize as long as the patient is symptomatic. So that's one important entity to remember. I don't know if Mr. Mark has got anything more to add on that. The fourth type of retention that we normally tell is what is clinical emergency. So retention secondary to acute neurological cause. That is the thing which needs to be sorted in the middle of the night. You need to get your neurological colleagues after catheterizing, because it could be a manifestation. This retention could be a manifestation of spinal cord nerve compression. Okay, so these are the 4. This is how I would bracket. When someone gives me a call, I just try to assess and see which group does he fall into, because that will help us in deciding how to manage the patient and when to manage this patient. Okay. Sean, you've got some, what is the question? Would the average talk time be altered by the cause? So this is, again, there is no definite time to say when to talk him, but the general answer to this would be, if you think the offending cause has been treated, then you can talk him. And if you think it's an acute urinary retention secondary to an enlarged prostate, then there's evidence to say you can give him an alpha blocker and you can talk him within 24 to 48 hours if he's clinically well. So you could talk him even 24 hours after you've started the alpha blocker. Okay.
I know we've got another question as well, mainly aimed at the consultants. Is the mechanism known for why alcohol causes acute urinary retention?
It's difficult. I think it's multifactorial. There is a neurological element. There is a bladder atony which can develop if sudden increase in bladder capacity happens. And sometimes there the BPH doesn't happen overnight. There is a background element of BPH symptoms occurring, and just an episode of taking alcohol can tilt the balance, and the patient can manifest. So these are situations wherein the triggering agent is something. It's just one episode, but there is a background element. So these patients might, just talking them alone may not need a definitive treatment. They might have background LUTs, which is where taking history becomes important, because if he has no LUTs, then he might a talk might be successful. But if he's got background LUTs, then that makes the long-term treatment for these patients different. So this long-term catheter. So high pressure retention. that is a big subtopic on its own. So if high pressure retention is due to bladder outlet obstruction, specifically due to prostate, then you think about surgical treatment. And there are various surgical treatments which the NICE has approved. And TRP is still considered the gold standard. Obviously, there are a cohort of patients who are unfit for treatment, who do not want any surgical treatment, and these are the group of patients whom we put on long-term catheter. So long-term catheter is a treatment, but it's something to be mentioned to the patient, and not all patients might take it. And there will be a certain cohort of patients who would be unfit for any form of treatment. And when you talk about long-term catheter, it could be just urethral catheter. You will find in the community a small group of patients who would probably be on long-term suprapubic. That's another option. And then there are certain young patients who are quite averse to the side effects of any surgical treatment. They do not want medications either. And these patients, I have a couple in my practice who are quite happy to do intermittent self-catheterization. So they keep the catheter for some time till their renal functions improve, and they continue to perform intermittent self-catheterization. So that is IAC in itself as a treatment for high pressure retention. Obviously, that's not the main treatment, but there are patients who are on intermittent self-catheterization for high pressure chronic urinary retention. Yeah.
Thank you, Mr. Kanda. That's very helpful. I think the last comment about someone about talk, I think, as Mr. Fernandez said, if you go high pressure, then your treatment talk becomes very different to that patient when you see them in your clinic or in your ward. You talk to them about conservative versus operative management, then you talk about risks and benefits. Or you've got so many options. That's a very big topic. But I think in the element, or if you're worried about acute retention, and for example, if it's a UTI and you've tried to talk them, then I think everybody is different. I don't know what Mr. Fernando's approach is, but sometimes I've seen bosses where they said if it's acute retention because of, for example, a UTI, it's been partially treated, you've still got positive culture at the time of a talk, then you give them another trial in 2 weeks' time as long as everything else is stable. But you can attempt another talk as long as you're sure it's not high pressure, if it's acute retention, depending on what people like to practice about if it.
Yeah, that's right. So as I said, the key here is if you think that the offending agent has been removed, then then he or she merits a talk. Yeah, and that could be a few days if it's a long-standing infection, if it's PPH and the renal function is normal. It could be an alpha blocker and then talk. So that is the thing. If you think it's been, or if it's constipation, which happens, then of course treat the constipation and then you can have the catheter taken out. There will be some patients post-operative post-colorectal surgery who develop retention, or that could be due to a neurological cause. That has to be dealt with on a long-term, on a medium-term basis, not talk straight away. So that's a different group of patients. But it's safe to remember this way, and that's the thing with urology is that it's all pathway driven. And if in your mind, you know which group or which pathway this particular patient is going to take, then you know the treatment and you're unlikely to get it wrong. There's one of the things, if you don't mind, just go back to maybe one of your earlier slides. I just wanted to clarify something, if you can.
2 seconds. I think I'll just shut down the PowerPoint. I'll get back up. It'll be 2 seconds.
Oh, okay, sorry. If you can. It's
sure.
It's on, I think the scenario 1, I think.
2 seconds. I hope it's going to be visible now.
Yeah. Says unable to urinate for 6 hours, unable to do. Yeah, what would you do? So I think this. I always tell whether you're going for your final year MBBS or you go for your MRCS exam or you go for your exit exam. The the answer is still the same. It's just which area you concentrate. So if you're going for FRCS exit, you concentrate more on the management. If you're talking about your NTN selection, we don't concentrate more on the management. For your number, for your SPR number, we talk more about history and clinical examination and so on and so forth. But the core still remains the same. So if you go on to the next slide, please. Yeah, so as I said, stick to the basics, A&E, A2E assessment, and clinical examination. And you mentioned digital rectal examination, is that?
It was there in this slide.
Okay, so the next slide, okay. So I think digital rectal examination, that is important, because that will sometimes give a clue. And this happens in the middle of the night, is that we always assume that it is a straightforward BPH, but you will get caught if you don't do a DRE and you're an SHU and SAU, or you're the registrar who's coming in the morning to do the ward rounds, and the SHU hands over and says it's a retention. Is that if you don't do the DRE, that might be a malignant prostate in which you put the catheter in, a good amount of urine comes out, but his renal function does not improve because his ureters have got blocked because of his prostate cancer. And again, doing a DRE, if you're finding a hard nodular prostate, will automatically trigger you to ensure that there is no neurological element which needs something doing urgently, like an MRI scan, starting on steroids, speak to the neuro on call. So I think the key here is, if you are a surgical trainee, if you're a urology trainee, ensure that you do a DRE. Just a DRE will help you to segment the patient in which group he falls under and how you manage him. So that is one thing. If you go on to the next slide, please. I think that's scenario 2. Go back to the previous slide. I just wanted to add a comment here. So yeah, I think insular gels. Difficult again to say which catheter, what the size of the catheter is. But of course, you can start with 14 or 16, and I think most trusts start with 16. And if the 16 doesn't go, you can try a 14 coude tip. So there are various techniques. Another thing, once you become a urology themed SHO or registrar, is if someone has, especially in the A&E, they've tried and they've failed more than once, and you're going to reattempt, consider giving a shot of antibiotic. Because these patients can go acutely septic with multiple attempts. Yeah, so keep this antibiotic protocol, because you go to every attempt at catheterization is actually an instrumentation, and if you're doing multiple instrumentation, there's a chance of UTI, sepsis, and then the whole thing changes. So that's something which I wanted you guys to keep in mind. And then if you move on to the next slide, please. Yes. So, is there a role for routine bloods? The recommendation from the NICE is you always have to do renal function test, because you will have lots of patients with a reasonably acceptable post-void residue, but his EGFR might be low, which will trigger an ultrasound scan, which will pick up hydronephrosis. Okay. So, I think the default is when it comes to you as an SAU, in the SAU, whatever be your level, ensure that you check his EGFR and a DRE has been done by someone reliable. If not, you got to do it. And then, as I said, you book the MRI if required for cardiac phenomena. Okay, the next slide, please. Talk we mentioned alpha blockers, and the next one, please. What are I think you've discussed this. I think so that covers the key thing. I think what is important is for you to have that thing in your mind, that when you're seeing a patient with retention, that you got to decide in the first few minutes when you're taking the call or when you're going to see the patient as to what group he falls under, and that determines the management and how you hand it over to your next colleague the next day morning, or if it's an emergency, pick up and speak to the registrar on call. So I think I've covered what I wanted to say. Anyone else has any other comments?
Yeah, sorry, it's Dave Mack.
Dave, yeah.
Just something completely separate is that, we've all talked about retention and everything. I think something that I always learned when I was a very junior doctor is that with acute urinary retention, generally speaking, it's very painful, and the pain should be relieved on catheterization. If you get it's not infrequently that sometimes we get referred patients with acute urinary retention. They have a catheter put in, and they are indeed they do have retention, but their pain doesn't go away. In those circumstances, it's really important to not get sidelined and think, oh, this is a retention. It's always important to look at, is there another pathology? Because invariably, if the pain doesn't go away once the catheter's in and the retention's been resolved, then there's something else going on. So in the setting of acute urinary retention, just be wary that once the catheter goes in, the pain doesn't go away, that you must think about other causes. But otherwise, in terms, I think, I would say for the presentation, you've covered a lot of the point. I mean, retention is not an uncommon a common condition that you will see throughout your careers at every level, and it's actually quite a more complex condition to it. It's not just straightforward retention. There are lots of, as you've heard, there's lots of different caveats to it and different types, and the management can differ slightly. But it's just to keep in mind the approach is very much the same, though. Renal function examination, history examination, renal function, and catheterization. Those are the finer points from a perspective of a junior doctor.
Thanks, Dave. That's good. Anyone else has got any other questions? Good. So, Sean, do you want to conclude the meeting?
I would love to. Thank you, Said, and thank you, Mr. Fernando and Mr. Mack as well, just for being able to add an element of context towards such an important condition such as urinary retention. I just want to thank everybody else as well for joining. If possible, we'll send out some feedback forms as well that will help optimize our service and help optimize the way that we run sessions in the future. Also added to that, we'll email you the link. It has been recorded, and in addition as well, we'll send you a link to actually come up and sign up to be a SFU member. It's free, and we send out regular email updates such as teaching sessions, also as well opportunities for post presentations and opportunities as well for essay competitions. So everybody should really join up, as it's free and it doesn't cost anything, and you can get some great benefits out of it. But I just want to say thank you to everybody for turning up, and thank you again for Saeed, Mr. Fernando, and Mr. Mack as well. So without further ado, goodbye everybody. Thank you very much.
Thanks everybody. Thanks,
thank you.
Mr. Fernando.
Well done, Sat. Well done.
Thank you.